So you see where I am. I'm back in the U.S. for about 2 weeks, so I'm glad I got to talk with you guys for a while. The end of the presentation is going to talk a little bit about my research, but not a lot because I'm in the early phases of that. So just for you to know, most of the talk is going to be about our cervical cancer screening program and just to give you a taste of what our clinical care is like in Kenya. First, I want to start off with a story of a patient that I saw just to give you a taste of how cervical cancer is impacting the women that we take care of in Western Kenya. I didn't take this photograph, but if you can imagine, this is about a 50-year-old Kalenjin woman who came to our clinic because she was having 2 months of very heavy vaginal bleeding. Her husband had left her and with no means of economical support, and she actually was brought in by her neighbor who was concerned for her welfare. So when I did a pelvic exam, I could see her entire cervix was obliterated by a fungating cancerous mass, and it was clear that she was continually leaking urine also at the time of the procedure. So when I did a bimanual exam, I could actually put both of my fingers all the way into her bladder, which had been completely eroded by the cancer. This is advanced stage 4 cancer. There's nothing that I can do for her now except palliative care. So which we tried to do and control for her. But this is just an example of the patients that we see every week, and this is something that should not happen. Cervical cancer is a preventable illness, and so that's why I sort of want to talk about why this research is important. Okay, oops, sorry. Where should I point this? So just a brief background on global cervical cancer. It's the second most common cancer in women worldwide, about 500,000 cases per year that are newly diagnosed and 250,000 deaths. Over 80% of those occur in areas that we consider low and middle income countries in the developing world. We know that persistent infections from human papillomavirus cause virtually all cases of cervical cancer. And the big issue with the rate of cervical cancer in the developing world is that we don't have effective screening programs. So even in the U.S., where we have a great screening mechanism, only about half of women are actually screened at the schedule they should be, compared with places like Kenya, where it's less than 5% of women get screened. This map I borrowed from the WHO, but you can see it sort of indicates the areas of cervical cancer incidence. Basically anything in dark red is an area of high incidence. So it's clearly a problem in the developing world. Just a brief slide on the anatomy of cervical cancer. It's very much a local spread, so not lymphatic or hematogenous. And the big thing, that probably caused that woman's symptoms, you can see here, local spread eroding into the bladder and then often into the rectum. So this is the progression of what we appreciate on exam, just stepwise, again, local spread and extension. The real area that my research focuses on more is HIV-positive women with cervical cancer. So I just wanted to give you one slide about the intersection of the two. We know that women who are infected with HIV are 4 to 5 times more likely to develop cervical cancer, and they're more likely, mainly because they're more likely to have a persistent HPV infection that they don't clear. These estimates in that third bullet point of 20 to 60% of HIV-positive women showing signs of cervical precancer is actually from mostly North America. We actually don't really know what the data is for areas like sub-Saharan Africa. Now I'm going to switch gears a little bit to talk to you a little bit about where I work and the clinics in that location. So Kenya is in East Africa. Eldoret, where we work, is right here, so very close to the Ugandan border and Lake Victoria. It's a very scenic, very nice country to live. Anybody who wants to come visit or do electives there or see us, we're happy to have students. Now just transitioning a little bit to talk about HIV in Kenya, just so you can get a scope of the prevalence of that disease, and then I'll move on to talk about how that affects our cervix screening program. So the estimated adult prevalence rate is somewhere between 6.3 to 6.5%. This is overall countrywide. Now, Kenya is about the size of the state of Texas, just to give you an idea of magnitude, but this prevalence rate differs drastically depending on what part of the country you're in. So Western Kenya has the highest prevalence rate of any area in Kenya, and you can see on the map where Eldoret is in that area. A recent study that I found from data looking at 13 to 34-year-old people, you can see that the rate is more like 15% overall, and in our catchment area, we usually say it's a prevalence of about 16 to 17%. What was alarming, though, in this data that I saw is that the age distribution. You can see in this area, women who are 25 to 29, it can be up to 36% prevalence. Men close to that same age, 40%. So it's hugely prevalent, and so that creates a huge problem for us, not only in treatment of HIV, but also prevention of other AIDS-related malignancies like cervical cancer. That last bullet point on the slide is a late-breaking data from one of my collaborators in Kenya who actually did just a genoprevalence rate of human papillomavirus in HIV-positive pregnant women, and we found that 98% of them are infected with HPV. So in a normal population, not HIV infected in the reproductive age range, it should be more like 80%. So if that's a group of women, we probably shouldn't even test them for HPV because we know they're going to have it. So that's pretty alarming. Now just to talk a little bit about the clinics that we work in. The place is set up as a consortium of universities within North America, and Moi Teaching and Referral Hospital and Moi University, where we work in Western Kenya. Duke University is one of the consortium members that has joined this program called AMPATH, which, as you can see, is the academic model providing access to health care. So essentially it started in funding with USAID to provide antiretroviral treatment to the HIV-positive patients in our catchment area. There's about 2 million Kenyans who receive care through them. Now they've sort of started to spread to chronic non-communicable diseases like cardiovascular care, diabetes, and cervical cancer screening became one of those goals that we were moving forward to treat. Our cervical cancer screening program, you can see the acronym there, actually began in 2008 as a research study with funding from the Fogarty International Center. And the biggest thing that we confirmed was basically an equivalence trial comparing visual inspection with acetic acid to the conventional Pap test. As you may or may not know, we don't do Pap tests in this part of the world because it's logistically difficult, follow-up is a huge problem, and we don't have pathologists to read them. So the goal for screening now in the developing world is really to move towards see and treat strategies where you examine at the time the patient comes to clinic, identify a clinically significant lesion that you would then treat, or do some sort of other plan for follow-up. It's on the order of years, as in not having women come back every year or 3 years for a Pap test. This is the main sites that AMPATH, or our consortium, works. So you can see Eldoret is the hub here in the center. Then there's 23 other locations all throughout Western Kenya, all of which have an established HIV treatment program, and we're slowly branching out to develop cervical cancer screening and treatment programs in all these sites. Right now we've branched out to Masoriat, which was our first site, Turbo was the second one, Webuye is the third, and now we're just starting training in E10. So things have been moving pretty quickly, and we're hoping that over time we'll get to every one of these sites so that patients won't have to travel so far to come into Eldoret. Now this is just a picture of the cervix cancer screening setup in our clinic. This is the main clinic in Eldoret, but pretty much all you need is household vinegar mixed with some normal saline and a camera to take digital photographs. This is actually our colposcope that gets projected onto this TV screen up here. For those of you who don't know, a colposcopy is when you examine the cervix under some sort of magnification to further assess any lesions that look problematic and take biopsies and that sort of thing for a further investigation. So this was the first clinic site that we had, and you can see it's pretty basic. You can screen this anywhere you can buy household vinegar, really. So just to give you an idea of the screening process, which is very different from the Pap test that we do here, women are referred either from the community or from another clinic in the building where they're receiving care. We do a pelvic exam, at which point exam is done before and after the application of acetic acid, or like I said, household vinegar for us. The acetic acid stays on 3 minutes. The nurses observe the cervix just with the naked eye, and anything that stains positive is considered aceto-white and concerning. So women who are eligible for cryotherapy, which I'll talk about on the next slide, will receive that immediately, and that is treatment for that problem that they've seen on that day at that time. Women who are not candidates for cryotherapy will then be referred to a consultant, which is like an attending's colposcopy clinic for biopsies and further management. Anybody they see that looks like frank cancer, one of the attendings gets called, we biopsy, and then we set them up for a GYN oncology clinic where they'll get surgery, or more often than not, just palliative care, because we don't have a whole lot of options for chemo, and we can't do any radiation in this site. So briefly, the criteria for cryotherapy, and cryotherapy is really just freezing the cervix with liquid nitrogen. You want to freeze it to a depth of at least 5 millimeters to kill all that surface tissue so that you can eliminate the changes that HPV has caused in that top layer of epithelium. So these criteria are in all of our clinics. All the nurses do this treatment, and they're very familiar with how to deal with these patients. So you can see a lot of patients can be treated on that moment. That day, cryotherapy takes about 10 minutes to do, and then they're gone, and they have their follow-up in about a year usually. How cryotherapy works, I joke this is one of our research coordinators, and he's, as you can see, almost as tall as a big cryotherapy tank, so it's a good thing he is bigger than so he can roll it around to our different clinic sites. But anyway, what he's doing is connecting the cryo probe, which you can't really see here, to the liquid nitrogen. You just turn it on, it gets really cold, and you freeze the cervix. This is great for genital warts and things like that too. So we have tanks at all of our clinic sites that are steadily replenished, because they do a lot of cryotherapy every day. Now these two wonderful ladies are our two flagship nurses. They're the first ladies who trained in Zambia on how to screen and treat. The lady over here, this is Grace, and this is Jackie. So they have been training all the other nurses that we see who come to the central area to train before they go back to their other site in Western Kenya. And I hope this works, because this is me interviewing one of the nurses, and she's talking about the program and how it started. I think I just clicked, maybe. Let me see. I should have told you I had a video. Okay. And then, yeah, it is. Let me see. Usually it works. Does anybody know how to do this? Sorry. No. I'm not sure. Okay.
Sorry, everyone.
All right, we might just have to forego that. That's okay. Yeah. Well, sorry. It's fine. She was just talking about the program and how she feels, but I just think it's nice for you to see some of the people we work with, but maybe another time. One of the key steps to our screening program, though, really involves patient education, because these women usually have zero to no interaction with any kind of formal medical clinic or medical program of any kind. And seeing, some of the places they live, like that picture on the first slide, you can imagine how they must have a lot of questions and be very unsure. What are all these people doing at the hospital? What does this mean? So this is a picture of Jackie, you can see here, educating a group of women before they get screening, just to explain this is what it is, this is why we're doing it, and this is what's going to happen, which is really the key in getting patients being willing to come and then also to return for follow-up. These pictures aren't great, but these are some pictures from our educational flip chart that the government of Kenya actually made to pictorially describe what happens in an exam. So this does look a little bit like the nurse is about to attack her with the spectrum, but at least they know, how they would be on the bed and the things that will be used. And this is a picture of one of the nurses just doing some education. This is one of the photos that they use to help kind of describe why we need to screen by using an ear of corn. So essentially you see these two ears of corn and you can't see that there's a problem unless you remove the husk to see the rotten kernels underneath. So they use that to try and explain, even though you feel like nothing's wrong, we actually have to look deeper to understand there might be something there that needs to be treated. This is another picture just of basic anatomy for women to understand what it is we're looking at. And then this is another example of how the cancer spreads or how they can explain it. It starts as a small rotten spot, but if you don't treat, can infect the whole fruit. And these are all things that the women there, analogies they thought of and created, which I think is quite ingenious. And this is just our crew in Eldoret. So this is Jackie, John, Grace, and Georgina. And they do a wonderful job screening all of our patients. So now I'm going to turn a little bit more to my research and talk about human papillomavirus, why it's important, and what we're doing to investigate it. So we know that all cervical cancers contain the DNA of human papillomavirus. It's the persistent oncogenic types that lead to precancerous and subsequent invasive cervical cancer. You can see there's the consensus there of the 12 HPV types that are considered oncogenic. And 90% of women actually, and this is usually data that don't include HIV-positive people, but 90% of women with a detectable HPV infection will actually clear it within 1 to 3 years. So it really is a natural history most often for women to clear it outside the setting of other, influencing factors on their immune system. And that sort of outlines the last point on this slide, is that there are serious differences with the immune response that affect viral clearance, such as things like HIV or even pregnancy. This is just sort of a diagram of, again, the natural progression of HPV infection. Most people with CIN1 or cervical intraepithelial neoplasia 1 will regress. The vast majority regress. And the tendency is for these two to not do anything extensive to treat that. About half of people who have CIN2, somewhere thereabouts, will progress, and then the vast majority, more like 80 to 90% of CIN3 will progress to invasive cervical cancer. So these CIN diagnoses is a pathologic-driven diagnosis. So that's something that we would do from a cervical biopsy. Anybody with CIN2 to 3 should be treated with some sort of excisional procedure. Cryotherapy can count as that, but a LEAP or a cold knife cone. So this is just sort of transitioning to the importance of global HPV genotyping and why we think that matters. So international data is starting to suggest there's some serious differences between the distribution of HPV genotypes among different subgroups of women. Now, we talked about the 12 oncogenic types, but there's over 100 different subtypes. And out of that, maybe 30 cause clinical disease, whether it's warts or dysplasia of some kind in humans, and about 12 of those we know are oncogenic. But out of those 12, we think that it's HPV 16 and 18 that cause about 70% of cervical cancer worldwide, but the vast majority of that data is from North America and Europe. There's a serious amount of data from sub-Saharan Africa, so it's really important to understand not just the geographical differences, but how HIV infection can affect the genotype distribution of HPV, and how also that distribution is affected by mild dysplasia and cancer. The mild dysplasia, the reason that's important is we know most mild dysplasia regresses, so there's no point in treating that. But the cancer you want to obviously know because you want to treat it. This also leads to possible implications for For vaccination, and we all know there are two major vaccines. They both target HPV 16 and 18, which is a good first place to start, because if we think 70% of the cancers are caused by those two types, that's important. But it might have less of an impact from a public health perspective to vaccinate a bunch of HIV-positive women in Western Kenya if most of their cancer is not coming from those two genotypes. Then moving on to why HPV genotyping is not just important in terms of knowledge of the disease distribution, but also used as a diagnostic modality. Cervical cancer screening everywhere is definitely, though slowly, moving more toward molecular diagnostics than just the conventional Pap test and visual inspection or colposcopy. So there's really very strong evidence to support the adoption of cervical cancer prevention strategies that actually focus singularly on the persistent infection with HPV, thereby identifying that not at just the time of first screening, but over time and follow-up. And the HPV test actually will more accurately predict the development of cervical cancer and its precursors more than cytologic, meaning Pap test, or colposcopic abnormalities. Because most of the time, cytologic or colposcopic abnormalities just reflect changes in the tissue from HPV change from any of the genotypes. Whereas knowing the different ones, meaning oncogenic or not, has more long-term prognostic value. And the last point really on the slide emphasizes why we're very interested in using HPV genotyping as a screening modality in low resource settings, because you can implement infrequent screening that's low cost but also has a higher diagnostic utility than using Pap tests. So what that would mean is doing an HPV genotype test at the time that you're doing a see and treat evaluation, knowing the types that are there, and then being able to gauge follow-up and how concerned you should be of the development of cancer down the road. So now just to talk to you about my two main objectives in the study that I'm doing now, which I have to say is funded by the Fogarty International Center and also the Center for AIDS Research here at Duke. The first is just to describe the prevalence of different HPV genotypes in HIV-infected women with mild cervical dysplasia and those who had biopsy-confirmed either severe dysplasia or invasive cervical cancer in Eldoret or in our area, Kashmir in Western Kenya. The second objective is actually to dig a little deeper into how immunocompromise might affect this genotype distribution, and to assess immunocompromise, we're just using CD4 count as a surrogate because viral loads are actually cost prohibitive to do in this area, so we don't do them very often. But to determine how our CD4 count relates to that HPV genotype distribution, and again in the patients with mild and severe or cancer. And again, the reason for that designation is the mild will usually regress, severe and obviously invasive cervical cancer, those people need treatment. So the study participants right now are coming from Eldoret, Turbo, and Masoriach. So you saw from that map those two sites that were our closest ones where we started the cervix screening program. We might be able in the future to expand to other sites, but right now we're starting there. So inclusion criteria, just older than 18 years, you have to have HIV, and you have to be able to give informed consent. The exclusion criteria are also very simple. If you can't participate, you've been pregnant recently, you might have some sort of cervicitis or pelvic infection or active vaginal bleeding, which should be addressed rather than enrolling you in a study, or having a history of a sexually transmitted infection that we know about in the previous 2 weeks. And the reason for that one is usually that can distort how well we can actually genotype the samples we collect, so we want to avoid collecting those samples. And again, this is talking about the patients from our two groups, the severe dysplasia, invasive cervical cancer, and then mild dysplasia, which in our case we don't define by Pap test, but just the presence of an aceto-white lesion at the time of visual inspection. The procedures are pretty simple. We're just collecting cervical samples by a conventional Pap brush that will be collecting in Pap media that we can keep and then transport to the lab for the genotyping. I'm collaborating with a group who has a lab in Mombasa. They're actually from Ghent University in Belgium, and they have the only lab that actually does a full HPV genotype in Kenya. So I'll have to transport all my specimens down there, but that hopefully won't be as difficult as other things have been so far. Patients who don't have a CD4 count within the past 6 months will get one of those. And then we have sort of a survey and a chart abstraction tool to get relevant sociodemographic and medical data to use to also associate with the samples that we analyze. But really, the long-term goals of the research are to, again, further allow the tailoring of treatment to clinically significant lesions, which is true here. There's a lot of false positives on PAP and colposcopy, and even in our case, in the visual inspections. We really want to try and narrow that down and treat the women that we know are at the most risk for developing cancer. We also would really like to pilot the incorporation of HPV genotyping into the screen and treat model in Western Kenya, which is what we're hoping to do with this study. And again, also to build a local capacity for molecular diagnostics at Moi Teaching Referral Hospital, which we're working on. The immunology lab is hopefully going to be setting up their own HPV genotyping. So the way we would see it is doing our usual screen and treat modality, but then taking a sample that could be genotyped for HPV. And QIAGEN has come up with a new test called Carry HPV, where you can actually do that at very low cost in 2.5 hours with basic lab setup. So that would be an ideal mechanism to have women know on that day what kind of treatment they would get, and then follow up tailored from there on out. And then I just have to thank all these folks who are on the slide. This guy is my Kenyan PI. He's a GYN oncologist. This guy is in Belgium, who's helping me a lot with my sample processing. This lady is a physician up from Brown. I don't know if you guys know Nathan Thielman. He is the director of the Residency Fellowship Pathway for the Global Health Center at Hubert Yergin Center. And Haywood Brown is the OB/GYN department chair here at Duke. He's very supportive of global health, so I couldn't be doing what I was doing if he wasn't in support of that. And of course, all the wonderful research nurse and assistants and everybody that I work with on the ground in Kenya. And that's all I have to say, so if you have any questions, feel free to ask. Yeah.
What's the timeline for your study?
Probably we'll get all of the participants we want. We started enrolling about a month ago, so it will probably be completed in 3 months, so by February. And then we're working on an R21 to get more money to scale up the research, essentially. Yeah.
Yeah, what are the range of technologies available for this genotyping test? Is it like PCR based?
It's PCR based.
Okay.
Yeah.
And then how what are the challenges of getting that type of technology to places like Elder?
There's a huge challenge with that. There's two main ways that the genotyping is done. It's either done as like a full exhaustive, all 13 oncogenic types, or there's a lot of tests that are just like oncogenic, yes, no. So DGHI has one of those from QIAGEN. Carry HPV is another one. So those ones are a lot easier to do and they're cheaper. The problem is they don't give you as much information as a full genotype. So I suspect what we'll end up doing is just using like DGHI or something like that, which is a lot easier to do at our site. And then if we need a full genotype, then we'll probably keep sending them to Mombasa, because that lab has to import all their reagents and everything from Belgium. So it's a huge headache. So I don't even think it's worth going that route where we are.
This isn't a very scientific question, but since I know more about your background, I was just wondering, I think it's fascinating. I was wondering how you got interested in working in Kenya in the first place and followed that through college and medical.
Yeah. Well, my parents, my mom's right here, so they were missionaries in Kenya, in central Kenya, so I grew up there. I was there for about 10 years from 8 to 18. So that really influenced my desire to do global health for sure. Going back to Kenya, I was a great thing for me. I mean, I was really comfortable there and knew a lot of people, and it was a great site to sort of get into from the OBGYN perspective, because Duke was looking to do that. But I decided to do obstetrics and gynecology really early, like when I was in high school, just because it fit with my worldview with global women's health and women's issues and things like that. But I would say probably the background living there for so long is what really influenced me the most. Oh, sorry.
Are there any efforts to vaccinate women against HPV?
There are, and that's a great question. So Gardasil has donated, let's see, I want to say 20,000 injections. So the first round of 10,000 came maybe a year ago. And they have been all dispensed, but it was tough trying to figure out who to give them to because it was such a small number. So we actually have 10,000 more that have been donated that we're in the process of trying to understand also how to distribute these vaccines, which is tough when you're picking who's going to get it and who's not. One of the other research studies we're also working on, though, is HPV vaccination acceptability among people, which is a big topic of research even here. But you can imagine it's a lot of times you're trying to educate people what it's about, why it's important. We want to kind of understand what are the big barriers to. Say we even got free vaccines to give to everybody, would people bring their daughters and hopefully one day their sons to get the vaccine? So that's about where we are right now.
Can you talk a little bit more about the social implications for women having HPV? You mentioned the story at the beginning. I know things like obstetric fistula are really socially debilitating. Is it the same sort of case?
It is in the sense, usually if you can find the problem in the precancerous or the operable cancerous phase, women can go back to their lives pretty usually, except there are some difficulties if you have to do a hysterectomy, especially in a young reproductive age woman, because a lot of the cultural value and worth in their identity is being able to have children. And usually if you ask someone how many kids they want, it's not like us who say, oh, I want 2 or 3. It's as many as God gives me. So that is a huge thing for women to think about, losing that capability. But what tends to be even worse is the older women, usually we see in the 40s or 50s, who come in like that lady I first talked about. They're inoperable, they're destitute poor, so they can't even afford any pain medication if we would prescribe it. So they are usually ostracized. So they're bleeding, they're leaking urine, they smell, their husbands don't want anything to do with them, so they'll kick them out. And usually if they can find somewhere to at least find a dignified way to die, that's usually the best thing that we can do.
In terms of the vaccination treatments you talked about before, how effective would they be if only distinct strains of HPV exist in that area of Africa? Like in North America, is there like a really big difference in the strains? Is there a distinct difference?
We think so, but that's one of the big things I'm trying to investigate. So I might be able to answer your question much better in a few months, but we think there is some difference. Whether that's clinically significant enough to affect the secondary prevention strategy the primary prevention strategy with vaccination, I don't know. I don't know if any of you know who David Walmer is. He's also in the Department of OBGYN. He's done a lot of HPV genotyping in Haiti and definitely found a significant difference in the prevalence of the oncogenic genotypes there. So, it's much more like 52 and 34 in that region than 16 and 18. But we'll see. I don't know if that's going to hold true in our population or with the HIV folks.
How common is it to do genotyping of HPV in the U.S.? I know we do a lot of pap smears and
exactly. Not common. In fact, when it does, when it is done, it's misused a lot, or just used for in a way that's not helpful. Like doing an HPV genotype on an H cell pap, there's no point because you know she's got HPV and a high-grade lesion. But the biggest time that we do it here is if you get an ascus pap or just an undetermined significance, you can see if the high-risk HPV is there or not. That's just a yes-no test too, so it's not a full HPV genotype. The other way we do, again, it's just the dichotomous genotype test, is as a modality for screening for women who are greater than 30 years old who've had normal paps for 3 years to go to every 3-year screening, just doing the digene HPV test. So really in the US, the only time we do the full genotyping is for research-related purposes, because there's so much data here, it's not really of applicable utility to use it in a patient care kind of way. Does that make sense? Yeah.
With the switching from annually to every 3 years, generally, I know that Dr. Walmer has faced problems with losing patients for follow-up, either annually or after an abnormal result. Have you thought about the self-swabs, or what do you think is the acceptability of that in Kenya?
Yeah, that's the next step that we can definitely look at. We know that self-swabs versus clinician of some kind collected ones are pretty much equivalent in terms of your ability to extract what you need to do the genotyping. We haven't done that yet in Kenya. I know there's a lot of people in South America who've definitely looked at that and found that women find it acceptable. That might be a next step for us to do. I think one of the biggest challenges in the US, and one of the reasons why it's going to be a long time before we move toward genotyping every 3 years, is people are so fixed to the idea of needing their pap test every year. You could tell them so much data about how it's not as good or whatever, and people are they'll still want it. And moreover, our entire gynecologic, preventative care system is based on an annual pap test. So people feel like they're going to lose their revenue if they start saying, well, I tell my young women they don't have to come every year. So I think it's going to be a long time before we go anywhere in the U.S.
So you think the self-swab might be acceptable?
I do. It certainly has been in many other places. I think they did a study in South Africa, I'm pretty sure. Yeah.
You alluded to some challenges earlier. I was wondering if you could talk a little bit about the challenges you faced in setting up your study.
IRB, big one. So you have to get IRB approval, which in my opinion the most important place is the place you're doing the research. And the university we're at actually has a really robust IRB department, but getting that approval, your consent forms translated and back translated in several languages, and the Duke IRB is, don't underestimate, this is probably the most difficult IRB I've worked with, and you have to budget a lot of time in trying to communicate that you're doing research in a place that's not here, and just explaining why certain things are structured a different way for a different cultural setting. Also, just kind of the logistics of getting things going, making sure you have a constant chain of supplies that you need, hiring good people that you know are into research or want to do the care and work with you, and then finding the money to pay for it, which didn't prove to be too difficult for me yet, but the IRB's probably been the biggest hurdle. And it's just because trying to do research in so many different sites can be challenging.